Charles Bonnet syndrome is a condition characterized by complex visual hallucinations, and I'll explain that in a moment, alongside deteriorating vision due to ocular disease, in the absence of any other psychiatric and neurological disorders, but with preserved insight. And what preserved insight means is that the patients know these things are not real. How do we know that our patients' visual hallucinations are Charles Bonnet, particularly with so many of our visually impaired patients being, older than us? They will have other comorbidities as well. So how do you know? And as optometrists, we probably aren't in the place to give the diagnosis of Charles Bonnet syndrome, but we can help by taking a complete history and to rule out causes, and then perhaps safely reassure the patient that perhaps this probably is Charles Bonnet, and maybe refer to the GP for sort of confirmation of that. What causes Charles Bonnet syndrome? It's basically lack of sensory input. Because not enough sensory input is going to the right place, the surrounding areas of the brain where the input is supposed to go in sort of try to compensate by becoming hyperexcited. This is what the frequency MRI studies have shown. If a patient with visual impairment is exhibiting Charles Bonnet syndrome, that's a good thing. That shows the brain is very plastic. It's trying to adapt to the vision loss. So you can present it in a positive way to your patients. How common is it? It's fairly common. Almost a quarter to a third of our patients with visual impairment do suffer from Charles Bonnet syndrome. Who's affected by this? What are the association risk factors? I'm sure we all know it's age, but this could be because visual impairment is high in older people. Gender, it seems to reported to be slightly higher in females, but again, this could be because women live longer than men. Ocular factors, well, it's more common in bilateral visual impairment, but it is reported in patients who've had one eye enucleated where the other eye is intact, and those with monocular vision loss due to other reasons. So it has been reported. It's just more common in people with bilateral vision impairment. And it's also more common in central visual impairment, but again, not uncommon in people with visual field defects, such as somebody with heminopias or glaucomatous visual field loss. What is the impact of Charles Bonnet? Until recently, we thought this was a benign condition. The patient knows it's not real. You just need to give them a pat on the back and say, there, it's going to be fine, it's not real. But a recent paper in the British Journal of Ophthalmology that was published in May this year by Dominic Fitch and his colleagues, it looked at the emotional aspects surrounding Charles Bonnet syndrome, which gives us a different picture of what patients might be going through. One of the questions it asked is, how did you feel when you first experienced Charles Bonnet syndrome? 12% said they were amused, 14% were indifferent, 20% said they were intrigued, and 10% said they were curious. However, a quarter of them, 25%, were startled by it, 15% said they were frightened, and 4%, which is small but not insignificant, said they were terrified. So just under half of them had some sort of negative emotional response to Charles Bonnet syndrome. So we do need to be aware of what patient might be going through and do something about helping them. How long does it continue? Again, until recently, we thought it happens for 12 to 18 months and then it'll go away. This is the advice we were giving out to our patients. This study was done through Macular Disease Society. There was a large cohort of patients, and 75% of these said they were still getting Charles Bonnet syndrome 5 years and on. So, it's not a problem that's going to go away. People need to learn to adjust to it. We as eye care professionals need to help that along. What types of images are seen? I think that can be important because if the images are scary, it's going to have more of a negative impact on the patient. And they can see all sorts. Things like peoples and figures and faces. The faces are described as grotesque. If it's something you come across for the first time, it can be very scary. Animals, if you've got a phobia of an animal, like a spider or a snake, you're going to overreact. And landscapes, which if you see a beautiful scene, you might be happy, but if you think you're hanging off a cliff, then you're not going to be very happy. So I think the types of images the patients may experience will have an effect on how they feel about it. Things that patients said that make their Charles Bonnet syndrome worse. They seem to be worse at night and in the evenings, and worse if the light is poor. In contrast, those who've been in very, very bright light said they also experienced Charles Bonnet syndrome after it. And being inactive, being sedentary, being alone is a factor that makes things worse. Tiredness, fatigue, nervousness and stress also increases these symptoms. What's going to help disable this symptomology? Putting on a light if it's dim or dark. Looking away and distracting yourself seems to help. Blinking a lot will help. Approaching the hallucinations and shouting and talking to them, particularly if they're people. How can you help our patients? Making patients aware and making health professionals or carers around the patients aware that such a thing exists, and normalising it as part of visual impairment will help, and reassuring them. As optometrists, maximising their residual visual field, reduce sensory deprivation and isolation, counselling and other psychological therapies, particularly if the patient's disturbed by them. Some papers have talked about psychotherapy techniques helping the patients come to terms with it. They don't go away, but they come to terms in that they don't bother them as much. So what should we be doing as optometrists? I think we should be asking all our patients who have some sort of visual impairment if they see it, because they will not volunteer this information freely, especially if they're afraid they're going to be labelled as being mad. And if they do own up to it, reassure them that this is a normal part of visual impairment. Inform the GP to make a formal diagnosis. More importantly, we can maximise their residual vision. Make sure that they're wearing the correct refraction, provide any low vision aids that will keep them more active. But also, if you in Leicester, we have a very good organisation for the visually impaired called Vista, which runs a befriending service. So you can, if you have something like that, you could refer your patients, particularly if they're living alone and you think they're isolated and lonely. You refer them to their local society for the blind. Refer for formal counselling if you think a patient's very emotionally disturbed by this. I would do this through GP though. I wouldn't leave the GP out of the loop.